Yeah, why don't we go ahead and get started then? So good morning, everybody. Thank you for attending today's Grand Rounds. I have the pleasure of introducing Dr. Jeff Gadsden from Duke University. Dr. Gadsden will be presenting the role of regional anesthesia enhanced recovery after surgery. So Dr. Gadsden was born in Canada, graduated from Queen's University in Ontario. He completed residency at the University of Toronto, and he next went to St. Luke's Roosevelt Hospital in New York for anesthesiology residency, where he became chief resident in 2005. He practiced in Canada for a short time and then migrated to Australia for a year and returned to St. Luke's Roosevelt in New York, home of the New York School of Regional Anesthesia, and worked with quite a team of characters there, including Admir Hadzik. He eventually left the colder weather and is now at Duke, where he's an associate professor and chief of the Division of Orthopedics, Plastics, and Regional Anesthesiology. He has over 30 peer-reviewed publications, many editorials, letters, and 19 book chapters. He's really a scientist. He's a consultant with Pacira Pharmaceuticals and Medical Device Business Services. All of these are in the world of regional anesthesiology and pain medicine, which is how I was introduced to him. We sometimes traveled together during the NYSORA Asia Symposia. I wanted to make certain that I used the word symposia properly, so I looked it up, and you can use symposia or symposiums. But I learned that it comes from the late 16th century, from the Greek word meaning basically sympoion, which meant drinking party. The root word meaning fellow drinkers together. So being 12 to 13 hours on the other side of the world and often jet lagged, I can honestly say this is the correct word for our symposia, because we did drink a lot of coffee and tea together.
Yes.
So here's to you. I told you, I promised I would bring you coffee, so here's your coffee. So with that, I'll turn it over to Dr. Jeff Gadsden. Thanks, Jeff.
Well, thanks. Thank you, John, for that introduction. It's great to see you again. We did have many good times overseas on those NYSORA trips, drinking lots and lots of tea and coffee. Can you see my screen okay?
Yes.
Okay, great. Well, and thanks everyone for your time this morning. I know it's valuable, and I appreciate the invite, the kind invite to come and share some thoughts with you about things that are passionate to me, regional anesthesia and enhanced recovery, and I hope to share some of our experiences and some of my thoughts on the matter. For those of you who haven't been to Duke, it's lovely. It's a very forested area, lots of trees, as you can see. There's a big Gothic cathedral in the middle of the campus. That's the medical school. This is what I see when I'm in my office. It's unfortunately literally just a picture at this point, but one day I hope to get a window and then actually see the campus. But fingers crossed. I do have some disclosures. I do consult from time to time for Pacira Pharmaceuticals, and I have received research funding from both Pacira and Mallinckrodt, but none of those really affect the content of what I'm going to talk about today. So I do want to talk about some of the advantages and limitations to peripheral nerve blocks specifically, less so about epidurals and spinals, but a little bit of both for enhanced recovery after anesthesia or after surgery. Highlight some technical tips for some of these blocks, and then examine some of the evidence supporting their use in ERAS. And of course, I think at this point in 2021, we've gotten the message about ERAS and what the goals are there. Improve value by increasing quality and decreasing complications, and then accelerating recovery and really getting patients out with minimal complications. And if I asked you, what do you associate ERAS with? What operation or what service line do you think would be most likely to incorporate ERAS? I think a lot of you would probably say colorectal. And this was certainly, at least in North America, one of the first things that other, but it's not necessarily the first time ERAS was done or done right. And I'll ask you, what were you doing in 1991? If, like me, you were being encouraged to stop, collaborate, and listen, which incidentally is the name of our journal club, you might recall that there were studies like these. And this is a study out of Sweden looking at a protocolized pre, intra, and post-op set of interventions and therapies that this group did for femoral neck fracture, which resulted in a decrease rates of delirium, falls, and length of stay. Now, you can look at that length of stay and say 17.4 days. Wow, remember, Sweden in 1991 is not the same as North Carolina or Wisconsin in 2021. So notwithstanding, you were able to show that protocolized elements and apply them thoughtfully, you can get some good results. And so this is a laundry list of cases with really successes. And you'll see that thoracic epidural was one of the things that we thought was really, really important for colorectal surgery early on as an analgesic intervention. But there's so many other things that go into that. Now, as we begin to expand ERAS into other areas, and we've done this, as I'll show you in a couple of minutes, beyond abdominal surgery, the question becomes, what are those important things? If you had to sort of prioritize all those elements, I think analgesia, and specifically non-opioid analgesia, and the reduced side effects related to opioids become more and more important. And I'm a regional anesthesiologist, and I like sticking needles in people, so I am biased. But I think that where we've kind of landed on this issue as we begin to explore other ERAS pathways at our hospital is regional anesthesia whenever possible. And if you look at orthopedics as sort of the use case for orthopedics or for regional anesthesia, it crushes outcomes. Now, see, I talk like an orthopedic anesthesiologist. It crushes outcomes. So we have all the good stuff that regional does for orthopedic and limb surgery, and we've known this for decades. And so here's a list of how we're beginning to employ regional in different ERAS pathways in our hospital. So we have colorectal with TAP or QL blocks, mastectomy, you get paravertebral. Increasingly, PECs and erector spine blocks for that as well. Breast reconstruction, hip fracture repair, of course, total hip and knee, arthroplasty. Cystectomy gets rectus sheath blocks now, whereas that used to get an epidural, living donor renal transplant, and we're working on spine and an XLAP protocol at the moment too. So, it seems like a Duke, if you're getting your toenail clipped, you are going to fall into an ERAS pathway at some point. So, and we're trying to see where we can make a difference in terms of the analgesia and opioid sparing. And it does, I do run into colleagues who sort of roll their eyes and say, oh, really, we're doing another block for a new set of patients. And I know it does seem like we're adding stuff to the workload, and you could punt to just plain old general anesthetic with some standard therapies. We look at studies like these, and this is Ian Harper's group out of Northern England, which shows that when they employed a regional anesthesia intervention, meaning spinal and a block, for hip and knee replacements versus what they were doing before, they actually were able to show an effective decrease in 30 and 90-day mortality, which is not an outcome that's usually on my radar for elective joint replacement, but an important one nonetheless. And so I often reflect on this bit of wisdom, where there's variation in practice, there are preventable adverse outcomes. And it makes sense to me. I think if I'm doing a total knee one way and Josh is doing it a different way, consistently, probably one of us will eventually get a different outcome than the other. And so, and this is not necessarily wrong, but perhaps better and not as good. And so there's, as I'm sure is the case at your institution, we're seeing this drive to protocolization based on an evidence-based pathway of assessment of our intervention and seeing what works and what doesn't. And then there's Jeremy. Now, Jeremy, so one of the things that we have to look at is how do you do that implementation of innovations? And so here's Jeremy. Jeremy's a good anesthesiologist, handsome looking beard. He's really, really good at what he does. And he's picked up a new block that he learned from Twitter, where we learn a lot of our new blocks. And he decides this is a great idea. We're going to start doing these blocks. So he started doing all these blocks in his patients. And what results in is a confused surgeon. This is what happened. This is the picture you get when you Google confused surgeon. Because, and they get frustrated because they're getting two different pathways. There's the Jeremy pathway, which might be very, very good. And there's the rest of us, which may be as good or maybe not so good, but it leads to confusion on the part of the block nurses, the post-op staff, the people who are giving the pre-op instructions, and of course the surgeons themselves. So one of the principles that we've tried to employ in our group is no superstars. So not to say that we can't all be superstars, but we can't have one prima donna and doing their own rogue set of anesthetic interventions, and then the rest of us not doing things. So, and the Jeremys are very, very important in the world. That Jeremy is how we innovate. So we take those ideas, we think of a thoughtful and thoughtful way to test them and then employ them. And I'll share with you how we did that with genicular nerve blocks a little bit later on. We do encounter barriers like, this is a surgeons saying, I don't want to block. And if your hospital is anything like any place I've worked at in my career, this has probably happened to you. Turns out Google Translate does detect surgical language. And when they say, I don't want to block, what they're really saying is, it's just inconvenient for me and I don't really care all that much about the patient, until you're able to educate them and show them that what we're doing is really making a difference. And you do have to have that evidence. One of the first studies I was involved in as a resident was a survey study where we asked surgeons in Toronto, said, hey, ACL repairs and your shoulder arthroscopies, what do you want your patients to get? Would you want them to get a block? And then we asked them a different set of questions. If you were getting an ACL or a shoulder arthroscopy, would you want a block? And 34% would say, yeah, let's give a block to my patient, but over half of them would prefer that they get a block for that same surgery, which shows you kind of their perspective. So it's incumbent upon us to be able to advocate for those patients and provide the evidence to our surgical colleagues. Now, I am biased. I love sticking needles in people, but there is a purpose to all this. And so in an ideal value-based care environment, I want to be able to show that my blocks are providing value and they're high quality and they're doing their job in terms of reducing pain. They're not causing complications and they're safe. But there's also an access issue. I can't create a set of blocks that no one else can do, because then it'll just be me doing them or someone else doing them. And so whatever you try to implement in these ERAS pathways has to be scalable and reproducible. And a good example is this. If you look at, this is a study that's just coming out in Anesthesia and Analgesia this month, looking at trends in peripheral nerve block usage for mastectomy. And we have known for decades that paravertebral block is amazing for mastectomy. You can do, and I have done, awake mastectomy under paravertebral block. It is so dense and so complete. And yet, knowing this, the uptake in that particular block prior to where when these data were collected was virtually zero. And because it's a scary block to do. And if you're not at going to pick up and look at what happened here about 2015, there's been an explosion in the number of blocks that are being done for mastectomy. And that's not because of paravertebral, that's because of things like PEX blocks and erector spinae plane blocks that people like you and I think, hey, that's a good block, maybe not a perfect block, but a good one that gives good results, is safe, and it's simple to do. So that's the trifecta: good, safe, easy to do. The blue bars here, by the way, are intercostal blocks. Those probably surgeons doing their own blocks for those cases. Interesting. So I'm going to actually go through two different cases here, examples, and show how regional fits into ERAS for these. And I'll talk about abdominal procedures and then total knee. So abdominal. We are a center that had a history of doing lots and lots of epidurals. And the problem with epidurals for abdominal surgery, and don't get me wrong, if I had a big midline incision, I'm pretty sure I'd be asking for an epidural. A well-done epidural is hard to beat. But in an era where you're also being told, hey, restrict the fluids or keep them just on the borderline of euvolemia, this leads to this problem. So they get fluid restriction, they get hypotensive on the floor, and yeah, we can get them through the case with a little low-dose phenylephrine infusion. But as soon as they're up on the floor, they get hypotensive, the surgical intern stops the epidural, then they get pain, then they get opioids, and so on and so forth. So a lot of our surgeons have come to us and said, guys, we're kind of done with epidurals. Is there some other thing that you can do for us block-wise that doesn't cause this particular cycle? And we do have answers for that. There also have been issues with urinary retention, not so much for the thoracic epidurals, but once in a while it happens. And then again, similar, lower limb weakness once in a while, sufficient that sticks in the surgeon's mind. Yeah, I had Mrs. H the other day, and she had a 2-day extended length of stay because she just couldn't walk or couldn't pee. And darn it, that epidural. Epidurals also are not perfect. And although it's something that we all do every day, unfortunately, the failure rate is not zero. And depending on the study you read, it can be as high as mid-20s%. This is one study that showed, the study was actually talking about whether you do it in the block area versus in the room, but their overall percentage was 16%. That's enough of a failure rate to make somebody question the efficacy of that intervention. And so we come to abdominal wall fascial plane blocks and what they can do for you. We wrote this review article a couple of years ago looking at the evidence to date on abdominal wall blocks, things like TAP and rectus sheath and QL. And the data was very heterogeneous. In a way, it was hard to compare many studies, but the upshot was there appeared to be early analgesic benefit and opioid reduction. So if you can get that local anesthetic in the right place, in the right plane, getting the right nerves, they seem to work. There are limitations to fascial plane blocks. And the first is that they can be trickier than they look. And certainly if you watch a YouTube video on tap blocks, you think, man, that looks easy, I'm going to do it. But they're often more nuanced than we think. And we do lack a complete anatomical understanding. And I'll show you what I mean. So here's a picture of an abdominal wall ultrasound. You can see the external oblique, internal oblique, and transversus. And the plane we want to be in is right there for the tap block. So we want to get that, peel those two muscles apart and let the local be in between. Trouble is, many times when I do these blocks, I find that my initial injection is either above the plane in the internal oblique muscle or below the plane in the transversus. And I find myself going back and forth and back and forth in an attempt to get that perfect unzippering, which is often elusive. And it merely makes sense to me that these Danish investigators found that when they did tap blocks in these ridiculously healthy volunteers from Denmark, their tap blocks resulted in a sensory distribution that made zero sense. It was all over the place, and you can see how they traced it out here. But it does make sense when I reflect on my own tap experiences. I think, yeah, my local anesthetic distribution was maybe not as good as I could have hoped. And so lessons learned, we endeavor to get the perfect unzippering of the tap plane. And this is what it should look like. Does it commonly look like this? No. This is an aspirational goal, but you'll see what's happening in this case is we open it up and then the needle gets advanced, and we open it up and the needle gets advanced. And so that was a change to our practice that really made a big difference. Before, we were just putting the needle in and creating a lemon or just a bulge in the tap plane and getting those jigsaw puzzle like Danish results in terms of our sensory distribution. But as soon as we started to stick and move, stick and move, stick and move along that tap plane, that changed how we were doing things. And so instead of lemons, aim for a banana along that tap plane. Go as far as you can posteriorly with your needle was what we ended up discovering. So, and then in terms of the anatomical understanding, there are times when we just can't unzipper that plane, and you have to make a decision. Am I fine? I'm going to pick either above that white line or below that white line. Go below, because what we know is the nerves for the tap run along that transversus muscle, not underneath internal oblique. So if you're going to have to layer it out below the fascial plane and not peel it apart, go below. And so these are examples of how we rush with enthusiasm to adopt a fascial plane block, for example, but have some early setbacks because of our incomplete understanding of either the technical variances or the where the nerves actually run. And so in 2021, we have a plethora of of fascial plane blocks, all with their own little alphabet soup nomenclature. Rectus sheath blocks, QL, ESP, tap blocks, and so which ones do we choose? And it really comes down to what are your sensory goals for your operation. So if you do a classic tap on the lateral abdominal wall, get this pattern of sensory blockade. Perfect for fan and steel incisions, for subumbilical midline incisions, even open appendectomies to the extent that they're done anymore. This is a good block. We are trying to protocolize this block for our cesarean section population, encountering some logistical issues related to who's available at what time of day to go and do that block, which is always the case with when you're trying to roll something out new that requires some extra effort. But this is a good block for that kind of incision. When we look at the tap block literature, it does show versus placebo, somewhat not surprisingly, that pain scores are indeed improved, at least at the 12 hours, and 24-hour morphine consumption is improved. So tap block, when you look at the procedures that it's meant for, not high abdominal procedures, but below the umbilicus, it does do a good job. And then for there are some data on colorectal surgery. Again, the heterogeneity is a bit troublesome because there are port sites and small incisions all over the abdomen sometimes, but there does seem to be, again, a decent opioid sparing effect for laparoscopic colectomy, which is good. One of the issues with some of these fascial plane blocks is that it doesn't many of them don't cover visceral pain. It's just somatic. So if the patient seems to be having an achy pain from all the pulling and tugging and puncturing of the peritoneum, you'll have to look to something else. And that's where the multimodal really comes into effect. The NSAIDs and the acetaminophen and the ketamine and the steroids and everything else that we do. All right, this is my favorite abdominal block, the rectus sheath block, and it's perfect for midline incisions. If you have a midline incision, I won't even consider a tap block, because this one is so much easier to do, and in my hands at least, so much more reliable. So my first question when someone calls me from the OR and says, hey, they actually had to open this laparoscopic case and we have a big incision now, can you guys do some kind of block? My first question is it midline? And if it is, rectus sheath all the way. And it turns out that if you put 30 mils either side of the umbilicus in the rectus sheath, we have cadaver evidence to show that it will travel up almost to the xiphoid and down to the pubis. So it doesn't matter where along that midline you go. This is an easy one and done on each side, 30 mil injection. You can put catheters here too. The rectus sheath accommodates a catheter very nicely. So either we as the anesthesia team or the surgeons can put catheters in the rectus sheath and then run them on a pump. Very, very effective. And I was somewhat, I've been a fan of rectus sheath blocks for a long time, but I was somewhat surprised to see this data because I grew up with epidurals, and showing that rectus sheath catheters are roughly equivalent to epidurals in terms of pain scores, time to mobilize, and length of stay for midline laparotomy, not laparoscopy, laparotomy. So that's impressive. The real trouble comes when I'm asked to solve this problem. So you've got incisions that cover the whole belly, and what do you do? There are places that will do what we call a 4-point tap, and we've done this. It just is a lot of work, and it's 4 chances to not get the block perfect, and then you've got a quadrant that's not covered, and it takes time. So it's not a simple procedure to go in and do 4 separate ultrasound guided fascial plane blocks. Another option for the total abdominal package, if that's what you need, is the quadratus lumborum block. And I won't go into the nomenclature and the nuances of the QL block, because it's a whole different talk in and of itself. The fact of the matter is you're putting local anesthetic really close to the paraspinal structures, the psoas muscle, the QL muscle. QL muscle, by the way, not a muscle I ever think I remember or heard of from medical school. Or maybe I heard of it, but I didn't pay attention until like 3 years ago. Now I know a lot about QL muscle, more than I ever wanted to know. But the point is you're putting local in a place that's very deep. It's not easy to image in patients that live here in the Biscuit Belt, and so it's easy to cause easy to have failures, I think. And so this is again another example. Here's where the nerves run in the QL block. So you're putting local in between the psoas muscle there and the QL right there. Again, not simple, not a block I would say teach to a CA2 on their first day of the block rotation. And then there's a rectus spinae plane block, which is the darling, let's say, of the regional anesthesia world at the moment. This is another block where if you do the PubMed search, it's just exploded. There's mostly case reports and case series, but people are using it for all kinds of things. Chest wall, breast, abdominal, spine, hip. And the reason is, if you reflect back on those goals, value, safety, and simplicity, it's very safe because you're coming down and you're on top of the transverse process. You're dorsal to that. So you're not getting anywhere near the paravertebral space and dangerous structures like the neuraxis. It's simple to do because you have a bony landmark, which is great for as an endpoint. You bring your needle down, hit the bone, and you're done. You lift up that muscle. The value part of it, remains to be seen. It's early days. And here's here's a little video of the local anesthetic lifting that erector spinae muscle off the transverse process. We're beginning to get more and more data on, high quality randomized control data to show that it does or doesn't in some cases make a difference in terms of relevant stay, patient satisfaction, opioid sparing, et cetera. But so stay tuned. I think there's lots and lots and lots to still be discovered about the ES block and where it really fits into our pattern. And then I'll shift gears here and just talk about something near and dear to my heart, which is total joint arthroplasty. And it's discouraging to me as a guy who likes doing regional to see data like this. This is data from the Premier database when they polled or they looked at peripheral nerve block and neuraxial use for total hip and total knee. And you can see in both cases, only a quarter of the patients were getting either one of those interventions for their procedures. And it's a bit strange to us because our baseline assumption is spinal anesthesia for the possible. And part of that is based on data like this. This Rogers study caused a bit of a stir in 2000 when it came out because it implied that there was a mortality benefit, a 30% reduction in mortality when you used epidural or spinal compared to just general anesthetic. Now, the data that this was based on was as old as 1981. So a lot of things have changed, and it's a valid question to ask: is this still relevant in 2021? So we looked to some of these big data studies out of database. So this is one that looked at, again, the Premier database, 380,000 patients, and they were able to show an association between neuraxial versus general in these orthopedic patients, and a reduction in infections and renal failure, and then also mortality. So there's that mortality signal coming out in a much more contemporary database, where we're kind of using the same medications, the same techniques that we're using today. That's impressive. So that's a decent reduction in relative risk for mortality. And this is another one. This is a single university hospital system in Toronto, about a decade's worth of data and 11,000 patients. And again, they looked at a bunch of outcomes. There's mortality again. So you're seeing a relative risk reduction association between regional spinal specifically and versus general in total knee. And then there's a surgical literature. So those are anesthesiologists making those arguments. So you could say those are biased, but I love seeing this kind of stuff in surgical literature because this is the American College of Surgeons NISQIP database data, 13,000 patients. If you do a spinal versus a general for total hips, you see significantly decreased surgical site infections, hospital length of stay, cardiovascular complications, respiratory complications. This is a separate one using the same database. Again, spinal versus general for hip. And they showed that if you have a general anesthetic for that operation, you're 26% more likely to have any adverse event, 27% more likely to have a blood transfusion, 110% more likely to have an unplanned intubation, which probably makes sense if you're intubating them anyway, but 380% more likely to have a cardiac arrest. So that's compelling no matter how you slice it. Plus, if you got a general, you took longer. You were 17 minutes longer in the OR, and that probably has to do with emergence and extubation and that sort of thing compared to spinal. This was compelling enough for the surgeon that they wrote an editorial saying regional anesthesia is more advantageous than general for total joint arthroplasty patients. And so you take something like that, and then you look back at that initial slide that I showed you showing that only 25% of patients across the country are getting spinals or getting peripheral nerve blocks. And you ask, why the disparity? Part of it has to do with the fact that when I grew up in residency, we were doing different kinds of blocks for our total joints. And so our total knees would get a femoral catheter and a sciatic block. And boy, they were comfortable. If I come to your institution and I'm getting a total knee done, please give me a femoral catheter and a sciatic block. Of course, the problem is you can't walk for a couple of days, and that's not great, especially if we're thinking about ERAS and all our goals, like getting patients up and moving and decreasing length of stay. Then there's an issue of falls, and what is the association between doing a femoral block, which obviously has an impact on your quadriceps function, and falls. It turns out that of all the things that could be related to falls, in again that premier database, this is out of HSS in New York, risk factors for falls were age over 55, if you were male, and if you got a general anesthetic. In fact, you were 30% less likely to fall if you got a neuraxial. There was no signal with peripheral nerve blocks versus no peripheral nerve blocks. So I think there's lots of factors there, how you're being mobilized, who's doing it, what your physical therapy protocols are, etc. But in 2021, there is no getting around the fact that there's an incredible pressure for us to provide a motor sparing technique for our total joints. Our surgeons are desperate to get them up and moving. And what's been amazing about COVID, and of course, it's been a horrible year for so many reasons, but a bright light, a silver lining is that because we're trying to reduce bed space in the OR and get people out, our outpatient total joint program has gone from sort of smolder to just most patients are going home the same day. And our motor sparing nerve blocks, which we were already doing, I think have helped accelerate that. So here's what we're doing for our total knees. We're doing an adductor canal catheter. We're doing an IPAC block, and IPAC stands for interspace between the popliteal artery and capsule of the knee. So that's an infiltration of the posterior capsule behind the knee to keep the back of the knee comfortable. Some blocks of the small genicular nerves that surround the knee. And you can think of, I like to think of this as sort of the whole blood thing that happened in the 70s. You know, back when, this is before my time, but there was a time when we gave whole blood and then realized, hey, you know, we're getting lots of immunologic issues with related to the white cells. So let's make blood components, and we'll give reds, and we'll give platelets, and we'll give plasma. And so I think of the femoral and sciatic as being the whole blood, and now we're just reconstituting the components in a way that sort of spares just that bad stuff, and the bad stuff here being motor weakness. So there we have it. We're sufficiently low down in the thigh or closer to the knee to avoid a lot of the motor branches that come off and get those quads. And many places do have their surgeons do local infiltration analgesia of the joints. And I have some thoughts on that. And there's data to support this, that it's extremely variable. It's very, very operator dependent, much more so than if I gave you an ultrasound probe and said, see that nerve, put local near that nerve. The surgeons are all over the place. And this is the video I just pulled off YouTube, but it's an instructional video of how to do local infiltration for a knee. Now that's the posterior capsule that they're going through now that the knee's open. Big sharp needle there. And what is behind the capsule, as you recall, yep, there are vessels, there are nerves back there, big nerves. That little chunk of fat right there is not going to hurt that patient afterwards. That's going to be well anesthetized. And of course, I'm poking a bit of fun at the surgeons here for doing this, but the data does show that it doesn't last that long. Surgeons, when they first started doing this, they'd come back from their meetings and show me videos of that someone else had taken in their institution of the patient walking with a cane up and down the PACU an hour after surgery. And that's great, but they never showed me the videos of what that patient looked like the next day, because they weren't that favorable. And so I'm not a huge fan of local infiltration analgesia. If you have a good infiltrator, that's great. I think that you get decent results out of that. The problem is the variability. And orthopedic surgeons are not known for being particularly patient creatures. So adductor canal block, for those of you who aren't in the orthopedic ORs routinely, our goal here is to get two of the terminal branches of the femoral nerve midway down the thigh, as I said earlier, to avoid some of the earlier motor branches of the femoral. And I did my own adductor canal block one day in the operating room. I was just bored and also curious. This is the early days when it started to first get some attention, because it didn't make our understanding of the block early on was this is essentially a saphenous nerve block. And it didn't make sense to me how a saphenous nerve block could do what it needed to do for a total knee compared to a femoral nerve block, which, as I told you earlier, I grew up with. And I mapped out my sensory distribution, and you can see that it's a lot of the leg, it's a lot of the calf, a little bit of the knee, but it's essentially a skin nerve. The good part is when we did a volunteer study looking at quads weakness in adductor canal versus femoral, volunteers got one of each block on each side of their body, zero quads weakness. So it was truly motor sparing. And if you look at some of the early comparative literature, femoral versus adductor canal, it does seem to be roughly equivalent in terms of pain scores afterwards and opioid sparing. And as I said, it didn't make sense to me at the time. I think our understanding of how this block has changed, and we realize that there's more importance now to that other nerve that's in that same compartment, the nerve to vastus medialis, which innervates a lot of that medial joint capsule. So again, it's fun that this is still evolving as a concept. But when we, in our own institution, compared femoral nerve block plus the surgeon squirting some local around the joint compared to an adductor and IPAC, we were able to shave off a day off our median length of stay. Our 24-hour morphine usage was halved. And most importantly to me, and I think also to the surgeons, the ambulation on post-op day one was remarkably longer. So that was a good outcome with that protocol change. The IPAC block is meant to address this, the popliteal plexus, and that's the you see that fine little meshwork of nerves that supply the back of the knee joint. So we'll have the patient on their side after the spinal is done in the pre-op. We'll put the needle in behind the knee, like you see here. That's that acronym. And here's what we're seeing. So we see there's a femur, that's the backstop. There's a femoral artery, and there's a sciatic nerve proper, so with tibial and peroneal nerves. And this is the space that we're going to fill up. So we're not anywhere nerve. We're just between the artery and the femur. And you can't see these nerves. You just see some space there. But you know they're there, and they do a good job of helping that back of the knee pain. We did a study looking at sham versus treatment, and this, just to warn you, is not yet peer reviewed. It's just been submitted for publication, so take that with a grain of salt. But the interesting finding was they were able to ambulate 3 times more in terms of distance with the treatment versus the saline. And I think that has to do with just the comfort they were able to achieve with extension. So watch for that, hopefully coming out soon. And then the last thing that we've managed to sort of try, evaluate, and implement in our total knee package are the genicular nerve blocks. And this is, as I said earlier, about the component theory of our total knee. This was always missing from our adductor and IPAC, because these nerves come off the sciatic and obturator and run around the front of the knee, but have a fairly big contribution. And so now we're getting these quickly after we do the spinal and then the IPAC, and then we'll flip them supine and do bang, bang, bang. These genicular nerve blocks are really easy to teach and do. They take about 2 minutes to do all 3 of them. And this is another study that we've just wrapped up and have submitted for publication. So again, not yet peer reviewed, but these are our results. We saw a 60% reduction in opioids on the first day, first 24 hours. And then if you look at the first 48 hours, there was still a 40+% reduction in overall opioid consumption. So a really decent, robust effect by doing these genetic nerve blocks. So based on this, we have now protocolized blocks, and they are part of our total knee package. So every total knee gets a spinal, and the drug that we use for the spinal has changed a little bit. We are using more short-acting spinals, mepivacaine or lidocaine in some cases, and because our surgeons are getting faster and we want those patients to get out, we still have some slow surgeons and they get bupivacaine. Adductor canal catheter, IPAC, geniculars, and of course multimodal analgesia. Does it take time? Our CA2, who's currently in the block area, yesterday did all those first 4 bullet points in 21 minutes, and she's just been with us for a week. So it's actually fairly easy to do in terms of once you get the pattern down and you're everything's ready to go. As there is for it, worth it. I definitely think so. And the data that I just showed you about the opioid sparing, I think helps to prove that point. This was an article that came out, and this in summary. This is an article that came out showing that, and the purpose of this editorial or this thought piece was that we've got a ton of blocks out there, and we can do all kinds of fancy blocks, but to address that point of access, to say what's a block that can be put into everybody's hands that gets good results. They came up with a list of Plan A blocks and then Plan B, C, and D advanced blocks. And I like this approach. I think it fits with our idea of let's make it a fairly simple protocol that everybody can follow. So my thoughts, I think regional should play a central role in almost every ERAS pathway. We do still have some conflicting data, especially on those abdominal fascial plane blocks, because of inconsistencies in the way that those studies were done, the techniques, how they're performed. And that brings us to the need for fewer case studies. We do not need another ESP case study. We need a comparison against a gold standard. And that gold standard is epidural for abdominal. And then we need some extended duration studies. How do you, it's great if a tap block lasts for 12 hours, but if I add dexamethasone, can I get that to 36? If I do a catheter, can I get that rectus sheath block to last for the duration of that XLAP patient's hospital stay? It's really important to get a friendly surgeon who can help you champion it. Again, I like the idea of one block or one set of block for each case type. Don't be a Jeremy, don't start going rogue. Train together. We have block meetings every 2 months where we sit down and make sure that we're all doing the same things and we're doing it the same way. And of course, do the whole QI process and make innovations thoughtful. I hope I've left some time for questions, and thank you very much for your time and attention. I really appreciate it.
Thanks, Jeff. Excellent talk. We really appreciate your time today and your experience and showing some of your new results from your data to be published. Does anyone have questions out there? If not, I have a few. So just chime in.
Thank you for your talk. Do you have recommendations for where to find resources to learn these blocks? Is it NYSORA? Are there like good review articles somewhere?
Yeah, it's I do. I can share with you. I'll send John some links that he can share with the group of places that resources that we use for both our trainees and also at workshops that we share with people that are trying to learn these. It's important to get the right resources. If you go on YouTube, there are a gazillion videos on tap block, what's the best one. And I think hopefully we've done a decent job of curating that, and I can share that with you.
That would be great. Thanks, Jeff. Anybody else?
Thanks for your talk, Jeff. Great talk. Just a couple of questions. I think some of these are probably universal issues, but because I encountered them when I was a resident and then also here. But I think major concerns that surgeons seem to have are that we're going to cause nerve injury that they'll be blamed for later. And then specifically for more perineural blocks, compartment syndrome. So do you mind sharing how you approach discussions on both of those topics with surgeons?
Yeah, that's a great point, Annie. And the nerve injury one I think is easier because we have numbers to share with them and say, look, if the risk of nerve injury is 1 in 5,000, and of those, most of those are transient and it goes away, and that's old data before we started using multiple monitors like ultrasound and nerve stimulation and plus or minus injection pressure monitoring if you're using that, et cetera. So we expect the incidence of nerve injury to be exceedingly low, and so low any discussion of risk benefit becomes almost ludicrous, because you can point to any number of studies showing that the benefit of a block in terms of hospital length of stay or patient satisfaction or opioid reduction, et cetera, et cetera, et cetera, is meaningful. And so the nerve injury thing, I think we have good data on that. Unfortunately, we're human beings, and I know of surgeons who have had a nerve injury and then it becomes experience-based medicine or complication-based medicine rather than evidence-based. And that one sciatic nerve block that caused a foot drop for weeks and weeks will stick in their mind, as it does in my mind when these things have happened. So, but approaching it with the data helps. The compartment syndrome discussion is a little more nuanced because we don't have a lot of data. And in a way, that's a good thing, because what we don't have is a single case report in the literature of a peripheral nerve block impairing the diagnosis of acute compartment syndrome. And the reason for that is, I believe, that it is very, very hard to mask ischemic pain. We know this when we do a spinal and then the tourniquet's up and the patient can't move their foot. They can't feel their foot somatically, but the blood pressure and heart rate start going up, and that's because they're getting ischemic. And as soon as the tourniquet goes down, that all goes away. They still can't feel their lower limbs. And so, in fact, a peripheral nerve block in a setting of, say, a tibial fracture probably, and has been shown in some case series and some case reports, probably serves to facilitate the diagnosis of compartment syndrome, because the patients are comfortable and then suddenly they're not. And that brings a nurse to the bedside, brings the orthopedic team, the APS team to the bedside. And then suddenly you got pairs of eyes and hands thinking, what's going on here? Whereas if you give a patient, and this is what I say to the surgeons, so that's the knowledge base. We have 0 case reports of a peripheral nerve block impairing. However, we have multiple case reports of the alternative, opioids. So you give a patient a PCA button, what's going to happen? They're going to punch it until they're sedated, and and then as they have increasing pain from their acute compartment syndrome process, they're going to keep pressing it and no one's going to ever know about it until it's too late. So that's a harder nut to crack, because again, horrible complication, and they're indoctrinated with this dogma, rightly so, at least in the beginning, that this is something we really, really want to avoid. But I'd love to see more data come out on. It's going to be hard to do that randomized control trial, though.
Another method we did in a previous life, which we published, and we're looking at bringing here, is a regional anesthesia follow-up clinic, where instead of trying to pass the buck to the surgeon and they have to manage any kind of a nerve injury, basically you take on that role and you give them some value add. Then you them to manage the patient, give recommendations, those types of things. So I think we want to bring that here.
That's cool. It's really cool.
So I've got a couple of questions for you. So with things like Exparel and work being done by Brian Williams with the adjuvants, what do you see in the future of regional anesthesia as far as doing away with peripheral nerve catheters? And part two is, will we ever get to a point where we can do the complete motor sparing block, the holy grail, with analgesia, excellent analgesia, just using adjuvants?
Yeah, that's a great question. Yeah, and I'll preface it by saying I do have a conflict of interest there. I have consulted for Pacira, so to understand that. I think it's an exciting time we're living in because there are some adjuvants like liposomal bupivacaine, or there's some of the pipeline that are about to be approved that are aiming to give that slow release. And so I love catheters, and I think there will always be a role for peripheral nerve catheters because they're titratable. So I can put a catheter in. If it's too dense of a block, I can turn it down. If it's not quite enough, I can turn it up. If there's a concern about compartment syndrome, I can turn it off, let the surgeons assess the sensation, turn it back on again. And so catheters are fantastic when they work, and there will always be a place for them. I think that where some of these other adjuvants, and that can be dexamethasone, dexmedetomidine, some of the extended release local anesthetics, where they have a place is situations where catheters are just a hassle. And so a good example for me in our practice is interscalene brachial block. We used to do catheters there for our shoulder replacements. But it's, the space from skin to plexus is like a centimeter or a centimeter and a half. And the neck is so mobile, those catheters got displaced all the time. And so the patients were actually worse off because they'd be going home and then the catheter pops out. And then now they're 4 hours away and can't come back, and we're trying to manage them with opioids. So I think that that's been a success for us is replacing a catheter with whatever long-acting stuff you want to put in there as a single injection.
Interesting. Thanks. And, as you try to, with regard to ERAS, you try to sort of standardize and have a protocol for specific to regional anesthesia where you have a certain block for a certain surgery. How do you balance that with the training and education of fellows and residents, particularly fellows where you're trying to teach them these more new and upcoming and more difficult blocks?
Yeah, that's an interesting question, and it speaks to those two competing priorities, right? So you want to protocolize things, but you want to make sure that you're a center where you're teaching all the blocks that are available, and so we just have to make those exceptions day to day and say, you know what, we're going to do an axillary block for this patient because you need to know how to do an axillary block. And I know that our protocol says X, but we're going to this is enough of a variation in the patient, how the patient's presenting, that we can justify doing something else. And thankfully there are enough of those exceptions, procedures that come through that are just a bit, the patient doesn't fall into the ERAS pathway. So, hey, you have total freedom to do whatever you want.
Excellent. And then regarding ERAS protocols, what is the secret sauce at Duke where the team there got the ERAS protocols introduced and implemented, and how is the anesthesiology department engaged with that whole program?
So I think what's been nice to watch, and I joined in 2014, so that process was already well underway when I got there, so I was able to watch it. Is the department leaders in this, and they're the ones that were kind of pushing for, hey, let's sit down at surgeon, nursing, physical therapy, anesthesia, and decide what are the goals and how can each of us contribute to the whole picture of success. And as we've rolled it out in different areas, spine, cystectomy, et cetera, it has really been anesthesia. The surgeons kind of come to us and say, I want better outcomes. And we say, we got it. We'll get back to you with a protocol, because it's, in many ways, it's rinse and repeat with some of the interventions.
Mm-hmm. All right, thank you for that. Any other questions for Dr. Gadsden? It's 7:30. All right, well, I don't see anything in the chat either. Oh, here's one. Would you modify a block or local anesthetic choice in a patient with pre-existing neuropathy?
Yes. So typically, so 2 points. One is we'll usually try to use the lowest concentration of a local anesthetic that does the job. So if someone has bad diabetic neuropathy, I'll often drop my concentration down, and because I'm mostly after analgesia. It's very seldom we're after motor block for any of these cases. Pardon me. And then, having said that, what we understand about local anesthetics and nerves is such that there's no evidence that applying local anesthetic to an injured nerve provokes or worsens or extends their disease process. So when that local anesthetic wears off, I tell the patients, you can expect your feeling to be exactly the same as it was before you came to me. And we don't think that there's such a thing as a double crush. We see that term tossed around sometimes. So no evidence to support that theory.
Okay, and we have another question from the chat. Doing single shot adductor selective tibial nerve block for ACLs at our surgery center. Everybody goes home. We have variable results, especially the anterior. Is going back to femoral better if they don't care too much about early ambulating?
I personally think so. I think a femoral gives you much more in terms of what it covers. It's a full femoral versus a half femoral, just to put it bluntly. The barrier you may come up against is there's a feeling amongst some of the sports surgeons that a femoral nerve block causes long-standing quads reflex disinhibition and injury, or not injury, but dysfunction. However, some of the more recent data and the best sort of EMG data that we've got shows that there is actually no difference between whether we block an ACL or don't block an ACL and the risk of that patient going on to have quads dysfunction. It's the surgery that causes quads dysfunction. And so we in fact do femoral blocks and sciatic blocks like you're doing, like a selective tibial. We actually do a little bit higher, but same idea. And the patients do great. And our surgeons don't, or even in athletes and the elite athletes, and the surgeons don't worry about it.
Excellent. All right, well, I believe that's all we have as far as questions. Dr. Gadsden, Jeff, thank you so much for your experience and your talk and your time today. We really appreciate you sharing that with us, and please keep in touch.
I really appreciate the opportunity. Thanks so much for all your attention, guys. It was great. It's great being here. So,
thank you. Have a great rest of your day.
You too.
Thanks,
Bye-bye.
everybody. Bye.